All right, here we are again, getting ready to look at the very exciting chapter on contraindications and indications for therapeutic massage. This is the content that will be heavily tested on the MBLEX, so make sure you pay attention to this chapter and a couple of other resources that I'm going to point out to you found in the appendix. So, chapter 6, here we go. All right. Chapter 6, Unit 2, glasses on, and let's go down all the way to Appendix A. Appendix A. I'm going to open that up and get rid of the table of contents here. This is an addition, a new addition to this textbook, and it gives you very concise information on the most common pathologies that you will need to understand as a massage therapist, and therefore tested on the MBLEX exam. So let's look at this appendix. So it talks about absolute contraindications. This is just where you don't do massage. Local, regional, avoid or modify massage in the indicated area. Cautionary conditions. Massage can be done, but it has to be modified. And depending on what's going on, you'd use critical thinking skills to figure out what the appropriate adaptation would be. So, for example, if you have an immune suppressed client, you're going to have to be extra attentive to safety and sanitation and hygiene. And potentially this is where you would wear gloves and a mask. If somebody has emphysema, it may be that they can't lay on their stomach, so in the prone position. So coma is an interesting one in this cautionary condition. There is some indication that somatic stimulation can be helpful for those that are in a coma, as well as maintaining a level of fluid movement and that sort of thing. But you'd have to consider that there's no feedback, that the person is unable to change their position for you, etc. So cancer is cautionary only because you want to make sure that you don't overtax a person's system when they're undergoing active cancer treatment. And then in remission, post-cancer treatment, there might be some ongoing side effects left over or persistent from the cancer treatment itself, not neuropathy, nerve, the chemotherapy, for example, as well as radiation, is damages the adjacent associated nerves. Local cautionary conditions would be where you would avoid the area. Chronic diarrhea is here because it would have to do with what type of massage you performed or if you avoided the abdominal area. So then there's these other important considerations, and make sure you slow down and read these and absorb them and comprehend them. And then it moves into almost a mini pathology book. So goes through and gives you the disease condition, and it's alphabetical. So here's an aneurysm, and then what is indicated or contraindicated. And this one says this is Contraindicated, refer immediately. It's a medical emergency. You're going to want to know these. This is, you need to know this. So down you go. And if you have working knowledge of this and a little bit, of a memorization process with this and a level of recall, you would recognize it if you saw it, then this is going to be adequate for the most part preparation for the NBLEX exam related to pathologies, indications, and contraindications. You're not being trained to be a pathologist or a medical doctor or a pharmacist or any of that. So it is important that we recognize the generalized ideas of things, that we understand or know how to reach more if that condition, client tells us they have that condition, and how to, some generalized starting place to make some decisions. This is based on entry level, all right, entry level. So somebody who is more experienced might work a little bit more focused than you would at entry level, but the NBLEX exam tests entry level. All right. Then we have these common skin pathologies that you need to be able to recognize. And most of these are contagious, not all, but most of these are contagious. So you're going to want to make sure that, this at least, at the very least, would be a local contraindication. Now, if it's something like psoriasis, and it is non-contagious and the skin isn't broken, then massage can be modified around that type of an area. Same with something like vitiligo. Another appendice that is here in the textbook that is helpful, although not directly related to indications and contraindications, but it is a quick muscle reference guide. So especially if you're looking at that functional mobility outcome, or if you're looking at a particular pain pattern or a referred pain pattern, this is helpful for a quick, concise study. And then it goes down through in chart form. And so let me get to, so here's quadratus lumborum, tells you what it does. And then the other column is the common symptom, if it's creating symptoms, trigger point, referred pain pattern. So this is really helpful. The last appendice we have is related to human trafficking, and we talked about that in the chapter 2. Okay, let's go back to the table of contents here and get our specific chapter up. And there we go. So as I give you guidance on this chapter, as far as the NBLEX exam is concerned, this is probably one of the more important chapters. So chapter 2, ethics, chapter 3, business, the terminology chapter, the research chapter, not as much, but it still creates a framework of benefit and effect and leads right into this indications and contraindications chapter. This is content that is easily tested on the NBLEX. So, if I was going to tell you to narrow down and review multiple times, these would be the chapters so far. So the first thing we're going to do is create a framework for what our long-term process or short-term processes with the clients. These are approaches to care. They're not outcome goals. But they overlap with outcome goals. So well-being and comfort care, palliative care, would certainly be supported by the relaxation research, relaxation-based research that we had talked about in the previous chapter. Restorative care is more related to helping a person maintain health status. Condition management, however, would fall into potentially the stress management, the pain management, or the functional mobility idea. And then therapeutic change has to do with a reversal of a condition. Massage is not necessarily, that's not necessarily the main focus of what we do, but it can be we can be part of a more integrated multidisciplinary team. And then this idea is, what is the dosage? How often, how frequently, how long, all of that. And then we get into pathology overall, and then we get into common pathological conditions and indications for massage, and then contraindications, specific contraindications, and I just showed you that appendix, and then our summary. All right, you know the drill with the chapter objectives. Can you discuss these? If not, or you stumble over it a little bit, then you need to back up and review. Key terms. This is the language you need to be able to recognize, reading, and speak. Here's the content about the concepts of how I am going to approach massage with my client, and this can vary. You might have a generalized care plan on condition management, but the person is very fatigued that day, and your approach would be more in the well-being, comfort care arena. So this is explained very well in the textbook here. And then down here in the dosage area, there is some research that can give us some ideas on this. And then based on this research, here's some recommendations that you would think about in terms of how you would create a treatment plan process for a client. So well-being, palliative, restorative, or well-being, palliative, comfort care as needed, 15 to 60-minute sessions. Certainly the overall recommendation is once a week forever, but the client may or may not have the motivation to be that consistent. That certainly is the case with restorative, but maybe not up here in the well-being and palliative area. This also could be where somebody gets a gift card, depending on where you end up working, and they don't really know about massage. This could also be in a resort area. Restorative, if somebody is really going to use massage to maintain and support their health status and to improve their health status, then it's weekly for about the 60-minute session. Now that doesn't necessarily mean 60 minutes on the massage table. It's usually about 50 minutes on the massage table, but more often in this situation is better than longer and less frequently. So every other week might work with this. Monthly is not enough. So that's why a lot of times you will see in membership models that the membership fee pays for the first session that month, and then there is a little bit of a reduction on additional sessions that month. And that supports this client that is coming in weekly or every other week at the very least. Condition management, this is where there is an underlying pathology, and the goal is to try to manage the symptoms as much as feasible. You certainly are going to be working with, they're likely to be receiving care from other professionals. It's depending if they're having a difficult week, maybe you would see them twice a week or weekly. 60-minute sessions ongoing. Potentially here, you would a 90-minute session may be indicated. It really depends, because if somebody has a chronic condition of some type, then they're already have some compromised adaptive capacity. In the restorative arena, especially if somebody has a physical job or a high stress job, and maybe a 90-minute session would be indicated. I'm not a fan of the 2-hour session. It just doesn't fit in with the ability to stay focused on the client. It doesn't fit in with various biological rhythms. But there are logical indications for 90 minutes. So this gives you some idea of that. The therapeutic change would be most likely in conjunction with an integrated system, like with a chiropractor or a physical therapist or some sort of a pain management team. Daily, twice a week, or weekly, but there's a definite beginning or end here. So there's usually a reevaluation in about 12 weeks. So 15, 30, you can find a 30-minute session in here. So this gives you just an idea of what they call dosing. We also have progression of care. I mean, somebody may have an advancement in a condition management situation, and they had a lower limb injury, and they were working with healing that. That's not necessarily therapeutic change. That's more within the condition management arena. And they might move up to restorative. So somebody might be in the restorative arena, but they're just want to have that full body, moderate pressure, rhythmic approach at any given time. So you can bounce around in these. So this is a proficiency exercise that's giving you an overview of what it's like to begin to adapt massage based on the client, not based on a protocol. So you're going to want to try. You're going to want to try to do this. There is an example here for you. And then, this gives you the idea of how that thought process goes. And then here is your client to try to do the same thing with. So chapter 1, chapter 2, chapter 4, all of these have led you up to this idea of developing and adapting a massage care treatment plan. And you're going to want to, there's a lot of self-reflection, a lot of going back and forth. Sometimes it's helpful to talk to a peer about this. But this is where you start to transition from, because you're also learning to do massage techniques and while you're studying this content. This is about the time in the program when you move off of the very beginning patterned process that we're teaching you, and you need to start thinking about it in terms of uh, outcomes and adaptation. And this is where you start to make the transition to therapeutic massage as a therapy, massage as a massage therapist. So this is a review. This is how we're going to pull things together. Here are the outcomes. Here's the approach to care. So I could have a pain management outcome that's condition management, or I could have a pain management outcome that is palliative, or I could have a pain management outcome that's based on therapeutic change. These bounce around, and they're pieces of puzzles that can uniquely be formed for an individual session. This should be familiar to you now. This is how you think through what you're doing. And then this gives you some examples here. All right, pathology. The reason why this is heavily focused on and heavily assessed is because when we are working with massage, it's always safety first. And if we don't understand the pathology, then we may not be able to adapt and respond appropriately, including referral and consultation. So pathology is important because it begins not just how you're going to work with it, but how you're going to be safe and do no harm. Okay, and I showed you this appendix. And it goes through and talks about different interpretations. It also leads you to the case studies in chapter 16, where we put this into context they're mocked up. I wrote those, but they're real life. They're based in real life scenarios, things that you'll commonly see. You start to read through those and you'll see patterns of how the critical thinking is used. So go take a look at that. And then it says to understand disease, we have to understand health. And so in chapter 2 in the Essential Science book, we had a whole chapter looking at mechanisms of health and disease. So you might want to go look at that and compare and contrast the information. So there is a state where our body is not functioning in what we consider healthy, but it's not also significant enough that it can be diagnosed. And so this is this dysfunctional area. Peak performance is also a strain on adaptive capacity, and it's not necessarily a healthy state. So we would look at a high performing athlete, for example, and we would say, wow, especially in the physical function, look at how healthy they are, how strong they are. That is not necessarily the case. When you are at peak performance, your next step on that is injury or illness, because you have made your body do as much as it possibly can before it has reached its limit. So you got to watch this. This can also be in terms of a stress load. A new parents at home with a newborn, and trying to adapt to that I would consider that, strained sleep, strained, you don't know what you're doing necessarily if you're a first-time parent, and all of that. I would consider that peak performance just as much as I would a competing Olympic athlete. So disease is what it breaks down. And homeostasis, all of the things that go on with that, are how we try to keep disease or pathological breakdown away. So how susceptible we are to that has to do with where our own physiological functioning limits are. So I've worked with a lot of professional athletes, and during the initial training when they're ramping up for a competition, uh, and they're increasing their intensity, it's very common for them to get a cold or the flu or some gastrointestinal thing, because their immunity is compromised. So that's kind of an example of how these functioning limits would have a broad effect. So here's that wellness continuum, and I mentioned that earlier, that wellness takes us to, we can't have peak performance if we don't start from the wellness area. And then as we move towards peak performance or maximal demand, then we can't recover, we can't restore. And then we get the breakdown, and hopefully we'll actually have enough time and support to be able to go through the acute phase of healing, the subacute, and the final stages. What typically happens is somebody, once they pass the acute healing phase, they feel well enough to go back to work or back to training or whatever, and they really haven't fully healed it yet. So you get this bouncing back and forth in here, and that could actually be how somebody would feel in that dysfunctional range. So this chapter's got a lot of language in it. You're going to want to know what the language means. We got communicable diseases, the difference between illness and injury. The book does a very good job explaining this stuff. Use the read tool you feature on this. Read it out loud. Novel repetition. You're going to want to get this information in multiple formats. Signs and symptoms, you want to know what the difference is between those. If it's bolded, it's a word you need to know. Here's a syndrome, and then here are various risk factors that increase the potential that we're going to fall into some sort of a pathological, or the homeostasis is not going to be able to restore. So we have genetic factors, environmental factors, lifestyle, age, pre-existing conditions, stress. All of these things make us more likely to have the potential to develop some of this stuff if we are not maintaining as good a homeostasis as we can. The next section talks about common conditions that you're going to find. So pain is going to be a biggie here if you look at this. So stress, inflammation, pain. Those are the biggies in through here. So this will be, again, another way of framing this content. This was discussed has been discussed in your essential science class, in your textbook. We've come across it in other parts of fundamentals book. It'll show up again in other chapters. So we really do have to understand stress. And the 3 stages of stress: fight, flee, freeze. We are just now recognizing more and more this freeze response, and how it can manifest in the difference between our actual perception of the stress and the reality of the external environment. And this is where breathing pattern disorder that we looked at in the last chapter comes in. And then how we try to adapt around all that. And it amazes me every single day when I wake up and I'm alive, how well and how miraculous the adaptation process is for our human experience here. We also need to look at the concept of resilience and what that means with the client and ourselves. And then here are the actual stress-related disorders. There's been an increasing awareness of trauma and trauma-informed care. When somebody has had trauma, and there's lots of different types of trauma, the event or the ongoing series of events makes a person come up with a coping strategy that saves their life at that moment, and it perpetuates and it sustains. So there are lots of forms of trauma. And if somebody is dealing, we pretty much all of us have had a traumatic or ongoing series of traumatic events. We all have a story. Every single one of us has a story or multiple stories. We need lots of levels of exposure and help and understanding. And you got to know that when you're working with trauma as a massage therapist, there needs to be other people involved. It's really important that you are in a consultation and a group network environment when you're helping people actively deal with a traumatic experience. When you're doing massage, somebody might have a recollection, a flashback, something like that. Part of trauma-informed care is you never try to trigger that ever. But if somebody becomes dissociated, and we'll talk about this more in future chapters, if somebody does that, then your job is just to be still and quiet and wait for them to get things resorted in themselves. If they can't do that, and depending on the level of the disassociation, then it could maybe progress into certainly a medical or possibly a medical emergency. This could be a situation where you might have to get a hold of an emergency contact. And this could be surprising. A person probably isn't going to come in on their health history form and say, I have trauma. So be aware, but don't exaggerate it. We've all had it. Everything that we have done to survive has been a solution. And sometimes what's just been so overwhelming or for such a long period of time that our whole physiology has changed. Our whole nervous system has changed around it. So these are some terms, and this is a link that can give you a lot of additional information about trauma-informed care and post-traumatic stress disorder. It's going to be, it's our job that if somebody mentions it to us, we understand it and we have a recognition, and then we research more. And if we are going to work with people, that we have the ability to communicate effectively among the support team. Pain and fatigue syndromes, along with anxiety and depressive disorders, are commonly interfaced with a person's way of coping with trauma. And remember, the way they coped was a solution. They lived through it. We don't want to throw that out. We want to be respectful and acknowledge it. They may just want to begin a process of where they are doing that with a higher quality of life. And then we get into the whole idea of when we may need to make a decision about referring out and working in more of an integrated process. So here we're going to talk about generally the indications for massage in this situation, more about trauma-informed care, and here are the principles of that. And massage therapy can be an effective aspect of a care plan, but additional understanding, more information, and developing another set of skills is often necessary if you are going to specifically focus in this area. So more resources for you here. Inflammatory response is now recognized that non-productive subclinical or chronic inflammation is the underlying issue for a lot of autoimmune conditions. And so managing the inflammatory response so that it is appropriate and supporting it when it is productive in the acute phase is important, but also what are the lifestyle changes? Where does massage fit in with that? If there is a chronic underlying inflammatory process, and stress will create kind of a subclinical inflammatory process. Here's information about tissue repair, and then it gets into, which is an inflammatory process and in a productive one. And then here we get into inflammatory disease, autoimmune conditions. Massage can help. So a manifestation of inflammatory response is pain, but you can have pain and not necessarily have an underlying inflammatory process. Pain can be productive pain. It can be an indication of potential danger, but it also can be non-productive, and it can change the nervous system, and it can become almost habituated. And that's the chronic pain, and that's the one that's very difficult to manage and to control. So this box is from the National Pain Strategy and its relationship to opiates, and massage is one of the recognized non-pharmaceutical approaches to care. So you're going to want to have an idea of what happens when a person is aware of a pain signal. And what is the difference between acute pain, chronic persistent pain, nociceptive pain, neuropathic pain, and then there is also mixed pain and neuroplastic pain. And each of these has unique features to it, but they all have the ability to habituate. And this neuroplastic pain here kind of is where that lives a little bit. You're going to want to know what hyperalgesia means, allodynia means, paresthesia. You're going to want to know what these terms are. And then the various experiences of pain and pain sensation. Again, the textbook does a very good job explaining this. We get into somatic and visceral pain, referred pain. That can be from a nerve impingement, potentially soft tissue, the trigger point thing. But certainly we need to pay attention to this viscerally referred pain, because the internal organs don't have an external representation. We can't look down like we can look down at our knee and say, oh, my kidney is not very good, or something is not happy in my gallbladder. So the reflex is up, it brings your attention to it in a somatic way. And so we need to be very aware of these typical referred pain patterns. So for example, it's very common over here, the liver gallbladder area here, it's very common for somebody to have an actual nerve impingement of the brachial plexus. And it'll manifest in these same areas as the liver and gallbladder. And we don't have the diagnostics to know the difference. So this would be a referral with some education to say the described sensations where I was talking to my massage therapist, they indicated that that could be a viscerally referred pain pattern, and that it would be prudent for this to be evaluated. Now, some of these are more of a medical emergency, and not all of these are as stereotypic as on this diagram. So this is the one for the heart, but the heart can show up in a lot of different ways. This whole low back area will show up with kidney, bladder, kidney infection. And it's important that that's not confused with somatic muscle bone joint pain. Because a kidney infection, a bladder infection that goes into a kidney infection, can be life-threatening. And it's especially problematic in people with some paralysis that are older. And so we want to really not just assume it's their low back. And look at the extensive area of the distribution. Ovarian pain is usually isolated right in this area. You've got your appendix over here. A way to sort of differentiate between visceral referred pain and more of a somatic muscle bone joint thing is that if it is muscle bone joint, you should be able to position yourself somehow into an ease position where the symptoms will diminish. When it is more of a visceral referred pain, especially if it's acute, you can't find your way away from it like you can if it's a sore muscle. So that's one way to differentiate. But if you're ever not sure, then you need to refer to make sure that this isn't what the person is experiencing. These are the dermatome areas where you can get referred pain when there's a nerve impingement. Phantom pain, they don't understand that really well. It could be some persistent sensation coming from the end of the amputation. They have done some interesting stuff with this with mirror therapy. So if the limb was there and then it's gone, it's been part of your imprint. It's always been there. So they put a mirror so that you can move the other limb and you see it in the mirror and it looks like you've got that limb there, and then you can do things like contract and stretch it and that sort of thing. Now, if you're born without it, this is not the case. And then cancer-related pain. Active cancer-related pain is considered acute pain because there's ongoing tissue damage. Cancer now is treated almost as a chronic condition, and the therapies can cause a pain process afterwards. And a lot of times it's a neurological or a neuropathy. And so the treatment of cancer pain is opiates are indicated. But after that, if there's neuropathy and it's that non-productive leftover pain, then those types of pain medications aren't nearly as helpful. So a lot of initial massage therapy research came within the oncology arena and how we can support people, mostly with fatigue, comfort care, and because we do see people more regularly, then we do want to be up on what the warning signs are and referral. Okay. And this box talks about how pain differs. And then, pain management is kind of a catch-all term, but there's a lot of different experiences of pain. So acute pain management is productive pain. And if it's local, this is always fun, this has to do with whether you use ice or not. The current approach on the MBLEX that I am aware of is that you do not use ice on an acute injury in the first 24 hours, up to 3 days. So that's during the acute phase. And the rationale is that is productive inflammation and you don't want to diminish it. You also, during that period, shouldn't take any kind of a inflammation reducing medication like a steroid or a NSAID, non-steroidal anti-inflammatory medication. And so more important is that you don't use the anti-inflammatory medication. And the effect of the ice is small enough on the inflammatory response that its pain reducing or pain management capacity can be certainly beneficial. So here are all the different things for acute care. Just remember, currently on the MBLEX, it's going to be no ice in the acute phase. Then we have to have a general idea of medication and how it's prescribed. And of course, we're talking about pain now. And the steroidal type medications, the narcotic-based, opiate-based medications, the the non-steroidal analgesics, the using them internally, and we have to fit into here the use of cannabis as well in this arena. So we have topicals that work locally, but thermal therapy, hot and cold, cold called cryotherapy, is really a good symptom management strategy. And then we have our terminal or palliative care and how that is treated, and that is certainly a comfort care. And the hospice, heard of hospice and how it is an important part of managing end of life care, and so the person is not experiencing pain. Here's where it gets dicier, is in chronic pain management. And um, how do, how does this happen? And how does massage therapy fit into it? And I mentioned earlier the idea of habituation of pain. So these are things that they're trying to do. TENS unit, that's what this is. Acupuncture, acupressure, distraction, imagery, biofeedback, aromatherapy, music therapy, hypnosis, hot and cold, and massage fits into this. And then there are other forms of therapy, and those need to be in conjunction with supervisory overarching care by a health professional with a broader scope of practice than us, and judicious and monitored use of medication. So here's a box on the opiate crisis, and opiates are not good. They work excellent on acute pain. They are not, and they work excellent for a very short duration. They are not indicated for chronic pain, and they don't do very well for neurologically based pain. Now, the cannabis does seem to have an effect on neurologically based pain through its internal network, and there's a lot of study going on with that. So here are your common pain conditions that you're likely to encounter. You've got your generalized stiffness, and stiffness, you want to challenge people to describe, because if it feels icky to them, quite often they're going to call it pain, but it really is more often stiff and stuck and tight. They might use terminology that way. If there's not enough blood to an area, it's going to be painful. Neuropathic pain is specific to the nerves. Impingement syndromes they are miserable. They're common in the elderly, unfortunately, because the skeletal structure starts to collapse a little bit. It's not a ton that you can do, but you can manage the symptoms. The massage can help with that. If it's really problematic, sometimes decompression of it surgically can be an issue. Sometimes they'll call this a pinched nerve. So you've got sacral, the cervical plexus, up, goes from the cervical area up. Brachial plexus goes from the cervical area down. And this is radicular pain, pain that follows a line. Lumbar plexus, this is common. They will try to decompress this sometimes with some surgeries. They have really improved the surgical process. If there is truly an impingement on the nerve, the surgical procedure will decompress the nerve, but the person still may feel discomfort related to all the compensation around it. That's for any of these. When we are involved with pain management, and how we are going to interface with that to improve the quality of life, then we have to have a solid level of understanding of how we evaluate it and the different types of pain sensation. And this gives us our indication for massage. Here is a box related to medical emergencies, and we need to know how to respond to that. Contraindications to massage. This is where we need to have a recognition, and it's really, really, really important to know when not to, and when to refer, and what type of information to provide that caused you to feel that referral was important. So again, here we get into a lot of detail. We have got our contraindication terminology. I already mentioned this when I showed you the appendix. There's examples here for you to take a look at in understanding the thought process. A general understanding of the categories of medication and what they do. Slow right down and pay solid attention to these medical emergencies. This can be as significant as a 911 call. Some of these are common, but ones that are not necessarily recognized is sepsis. That is more common than you would think, and it can show up and exacerbate very quickly. So here's the symptoms of this. This is a medical emergency. This is 911. Anaphylaxis. Somebody who is susceptible to an allergic response usually has an EpiPen. You need to know how to use that. Symptoms that develop quickly is something that we need to pay attention to. Diabetic emergencies. Again, somebody knows they're diabetic. You need to ask, what should I do if you are going into some sort of diabetic strain or stress. Rhabdomyolysitis, rhabdo for short. This is more common than one would think, and it has to do, it's a poisoning. It has to do with components of a muscle injury getting out into the bloodstream, and it's very, very hard on the kidney and the liver, and it actually can come from a very high fever, a lack of blood to an area, and just a note here, aggressive heavy pressure friction massage can cause mild cases of rhabdo. So a client should not be sore and stiff and after a massage, especially generally feel like that. That may be a small area that's tender to the touch, but it should not interfere with movement. It should not be an over, a conscious experience of, oh, I'm so sore. Or any kind of flu-like symptoms or anything. That means that the massage was too aggressive. It is in this spectrum of rhabdo. Seizure, you need to talk with a client who possibly has some sort of seizure disorder. Ask them what they want to do and how you need to accommodate to that. If it's aggressive, if you don't know what to do, if the situation is overwhelming, then it's a 911 call. Not Not always does it have to be a 911 call. So you want to communicate with your individual client. And then we need to be aware of endangerment sites, cautionary sites, etc. These are spots that if you press into them, you can either close off a vessel or damage it, or you can break off a little appendage, or a little prominence on a bone, or you can put too much pressure on a nerve. Nerves don't like that. Vulnerable soft tissue areas like the anterior of the neck, because there's a lot of adjacent um, endangerment sites in the area, the eyeball. So that's what these are. So you would probably avoid the eyeball, right? But the area in the back of the knee where there's the popliteal artery, you wouldn't avoid it. You would just alter your pressure. So some of these are a total avoidance area, and others of these are more adaptive. Okay, the next segment here is going to talk to you about recommendations for referral. Gives you an example here. Always pay attention to your focuses on focus on professionalism. Here's kind of a consolidated list for potential referral, especially if it is not understood, if it's not logical. So for example, if somebody has edema, but they're close to their menstrual period, they've eaten a lot of salt, that might be logical. But if that same thing shows up and you don't have a logical reason for it, it could be an indication of something else. And these indications here show up in a lot of different conditions. We need to recognize this. We don't need to connect it to a specific condition, but we do need to know if there's a rash that's not explainable, and there might be some other symptom that goes with it. That could be a skin infection, that could be a sign of a viral infection. There's all kinds of things that could be going on. So we need to recognize these things, and then help the client understand the importance of why we are referring them, and why they need to follow up on that. Here's a proficiency exercise that sends you to Appendix A and puts you into a critical thinking process. And then here we are with our foot in the door. So summary, learn more on the web, use your Evolve site, references, and multiple choice questions. Important chapter. This is a chapter you need to come back to frequently. This content will, in some form, be tested on the NBLEX exam. It's important. This is important information so that we support a client with our benefits, but we are always looking at safety first.